Hello everyone, this is Dr. Pruitt. Welcome back to this week's EKG. Thank you for joining us. Today we've got a case of an 89-year-old female who called 911 because she feels like her heart is racing and she's dizzy. She's got a history of pulmonary hypertension, GERD, fibromyalgia. She says that 2 weeks ago she saw her doctor, was told that she had an episode of atrial flutter, and it feels like she's having that again. So you get your set of vital signs, you look at those, and you have a heart rate of 150, which should catch your eye. And then she's very hypertensive at 198 over 111. Oxygen's 95. She's breathing about 20 times a minute. She's talking to you. She's awake. Her sugar is normal, and her end tidal is just a little bit high. Here's your 12 lead that you get. I'll let you take a look at this and see what you think, and then we'll go through it together. All right, and so we start with our rate. Our computer's telling me that our heart rate's 143. Let's look at this and see if we confirm. So I find a QRS that matches up on a thick red line, and then I'm going to count down on the thick red lines. So 300, 150. Okay, let's see another one out here somewhere. Do we see one that lines up? This one kind of lines up here. I have 300, 150 again. And then same thing over here, 300, 150. So our heart rate is actually pretty close to 150. 143. When you see a heart rate of 150 plus or minus 10, down to 140, up to 160, you need to think a flutter. And so the reason I'm saying that right now is because when you're thinking a flutter, when you see a heart rate that's kind of parked right at 150, and it looks very regular, but it's hanging out right at 150, then look at your P waves, because they're hard to discern here, but there's something in a flutter that looks like sawtooth pattern. Do you see it? It's very pretty, but it's hard to discern P waves, and I would actually wonder if these are upside down right here, and there's 2 to 1 conduction. Do you see that? And so we see that in lead 2. Sometimes V1 will be helpful. It's not so helpful in this 12 lead, but that's what I see here. And they kind of march out all the way down. So there's a beat, no QRS, beat, QRS. And if you march out that atrial rate, here's a beat, and then here's another beat. That's an atrial rate of 300. That atrium is beating very fast, but it's not being conducted. It's being slowed, and then every other beat is being sent through. So we have a rate of 150. So it's a regular rhythm with an atrial rate near 300. That's what we have for our rhythm. And then our axis. So we look at leads 1 and leads AVF. Remember, lead 1 is our left thumb. We're up in lead 1. We're up in AVF. We have 2 thumbs up. I'm happy with our axis. We're looking at our intervals now. We move on. QRS is less than 120, so it's narrow, which you can tell, you would agree by looking at it, except for this one here. So we do have a PVC, but I only see that one that's wide and looks a little bit like it doesn't fit. But everything else looks narrow to me. Then we look at our QTC, which is kind of hard to tell because it's really difficult, except maybe over here, to see some P waves. So QT is okay, it's less than 450, nothing that I'm worried about there. And then we can move on to our ST segments. So I like to look at this in a territorial distribution. 2-3 AVF are our inferior leads. It's very hard to find a baseline here, which is another clue to atrial fibrillation because there's no clear T waves. How do you know your TP segment? Hard to tell. So I would, if you just pick a line and draw it, it's really difficult to tell, but I don't know, it doesn't look like a STEMI. I don't see clear ST elevation. I don't see any big tombstones, but I do wonder, there's some inversion here, and depending on where the baseline is that depressed? I don't know, maybe. Let's move to 1 in AVL and see if anything else catches our eyes in terms of ischemia. So this actually looks pretty flat to me, looks okay, but again, maybe an inverted T wave if that's what that is. Nothing super standing out, but maybe some kind of diffuse depressions or T-wave inversions here. Moving to our septal leads, this looks okay. And again, really hard to tell when you don't have a baseline, but maybe a little bit of subtle ST depression there. Same thing here, a little bit of ST depression. So I just call it kind of diffuse ST depression. And we do have an 89-year-old with a heart rate of 150. So it wouldn't surprise me if she's not tolerating that heart rate very well. And the one thing I didn't look at, which I hope you picked up on before I'm mentioning it now, is AVR. So we actually have greater than 1 millimeter of elevation in AVR and some kind of diffuse depressions everywhere that aren't really in a pattern. And so would I call this a STEMI? Not necessarily. I think these are some rate-related ischemic changes, so she's not handling this rate very well, as evidenced by some of these ST depressions. With a ST elevation in AVR makes me wonder if she doesn't have some subendocardial ischemia, so part of the heart isn't getting enough blood flow as it's beating so fast, or maybe she's actually got some coronary artery disease that's causing these manifestations of some suggestion of ischemia in the setting of a really fast heart rate. So not a normal EKG, looks like classic A flutter, but also there's some signs on here that her heart does not like beating this fast. There's a lot of oxygen demand going on there. So EKG features of atrial flutter, like I said before, you really need to think about it anytime you've got a heart rate of 150. A lot of times atrial fibrillation and A flutter get plugged in together, but there's a big difference. Atrial fibrillation tends to have rates that are all over the place. A flutter tends to have a very consistent rate of very close to 150, very predictable, usually narrow. I call it kind of pretty. These sawtooth waves kind of look very organized. And it just depends, the rate just depends on how many of them get through. And so we had 2-to-1 conduction on our 12 lead. If you remember, we had these inverted P waves here that were coming through. So that was A flutter with 2-to-1 conduction. But these waves are happening at a rate of 300. And so it's pretty typical that your atrial rate will be around 300, sometimes with a rate of 150 with the ventricular rate. It looks like a sawtooth, very easy to see in 2-3 AVF, just like we saw in our 12 lead here. Sometimes V1 will help you. Our V1 wasn't that helpful. And then loss of the electric baseline, which we saw. And then really the ventricular rate is going to just depend on how many of those atrial impulses are able to get through. And what's happening in atrial flutter, this is kind of a form of SVT. There's a re-entry track in the right atrium here that's constantly sending signals around, and every once in a while, 1 or 2 of them will get through and then cause ventricular conduction. And so it is a form of supraventricular tachycardia. We mentioned an atrial rate around 300 is very characteristic. And then it's going to be very mathematical. So depending on the number of impulses that get through, you're either going to have a rate of 150 if it's a rate of 2-to-1, you're going to have a rate of 100 if it's a rate of 3-to-1, or a rate of 75 if it's a rate of 4-to-1. Okay, pretty consistently though, your atrial rate's going to be 300, so pay attention to that atrial rate. Look at those P waves and see where they march out. Now, very importantly, I mentioned this is an SVT and a reentrant tachycardia, but this rhythm doesn't really respond to adenosine like a normal SVT would. So you really want to treat it like AFib, which is why I think they get lumped together very frequently. They're treated with rate control, so if you have the option, you can give diltiazem, metoprolol maybe. If they're unstable, treat them like an unstable AFib hypotensive patient. Cardioversion may or may not help. It's worth a try if you find yourself in that situation. If they're unstable, a little bit less of a risk for stroke, but not as much. So still be careful about that. But give aspirin, treat symptomatically. A lot of times AFib can be precipitated by something else. So ask questions like, is there infection? Are they dehydrated? Something else you can treat that may help them feel a little bit better. And then rate control will ultimately be the answer here. So this was a good one. Burn this one in your head. These nice sawtooth waves in leads 2 and 3 with an atrial rate of 300. This is what atrial flutter looks like. So thanks for joining us this week, and we'll see you next week for another EKG.